Good afternoon. We're here at ASH, and I have with me Francesca Gay, Dr. Francesca Gay from the University of Torino. She's a myeloma expert in that part of the world, and she has some really interesting data to present around a study, a randomized study, looking at the newer agents compared to the not so new agents. And she's here to tell us a little bit about those results. So, Dr. Gay, would you please tell us about that study?
Yes. First of all, good afternoon to everyone. Well, our study is a randomized study that tries to answer to many questions. The question we are analyzing now is the comparison between two different induction regimens for newly diagnosed patients with multiple myeloma that are eligible for high-dose chemotherapy and transplant. And these patients were randomized to receive treatment with carfilzomib, the second-generation proteasome inhibitor, plus lenalidomide or plus cyclophosphamide. Basically, we performed this analysis on the first 300 patients that were enrolled to look at the preliminary safety data. This was a pre-planned safety analysis that showed that the two treatments were very well tolerated. There was an increase in the non-hematologic adverse events in the carfilzomib plus lenalidomide arm, but these were mainly events represented by dermatologic toxicity, reversible rash, or reversible increase in the liver enzymes. Then we looked at the efficacy results that, even if preliminary, are pretty good. We saw that response rate was high in both arms. In both arms, patients achieved 90% of patients achieve at least a partial response.
In both arms?
In both arms. The deepest response were achieved in the carfilzomib and lenalidomide arm, however, with the combination of the proteasome inhibitor and the immunomodulatory agents. We saw that around 70% of patients in the KRD arm achieve at least a very good partial response versus 60% in the KCD, which is good, even if less higher than with KRD. With KRD, also CR rate were higher than with KCD. And we also performed a preliminary analysis on MRD on a subset of patients, subset of VGPR patients, and in these patients, 50% of patients in the KRD arm achieved MRD negativity in comparison with 30% with KCD. So again, very high in both arms, higher with KRD compared with KCD.
And which method did you use to test for MRD?
These are MRD results based on flow cytometry with a sensitivity of 10 to the minus 5, second generation flow. We are performing also next generation NGS, but we do not have the data yet.
Okay, excellent. Yeah, there's a lot of interest nowadays in that technology and comparing that to flow. Fantastic. So clearly the regimens that you're talking about are used all over the world, and they're applicable all over the world. How do you see this impacting the treatment of multiple myeloma, these preliminary results, or is it too early yet to be able to make conclusive statements? What's your thoughts?
Well, I think that these results show that we have two second-generation proteasome inhibitor combinations that work very well in newly diagnosed myeloma patients. We see also that the combination with the proteasome inhibitor with the immunomodulatory agents is probably more effective and is well tolerated. All the toxicities, even if a bit higher, were manageable. So these are two important messages. These are, I believe, two important new possible options for the treatment of newly diagnosed patients. We need, of course, a longer follow-up and mature data and data on all patients enrolled to confirm these results, but the difference between the two arms is already significant. So I hope and I think that with the longer follow-up we will confirm these results in the whole series of patients.
It seems like maybe next year at ASH we can have another conversation and
Let's
perhaps
hope
have
so,
that,
yes.
that data has matured.
Yes, the data on the induction, I think, of course. Then the protocol goes on with transplant and consolidation, and then there will be a maintenance phase. But definitely the follow-up is too short to try to answer to the following questions.
Wonderful. Well, thank you for sharing these preliminary data.
Thank
It's very
you.
encouraging, and thanks for stopping by.
Thank you.